de medicamento, lhe ensinar que tem que tomar todos os dias.
Eu gostei do meu trabalho.
Technical team to then stop it. Yes, thank you so much. So good morning, everyone. I love a lively room, a fun room. I know we are tired, we haven't had coffee. Welcome to our session. And you are all on time, so clap hands for yourselves.
Muito orgulhosa porque eu estou para ajudar as mães grávidas e latantes para que elas estejam saudáveis e saudar e também as crianças saírem saudáveis.
Sabemos que toda pessoa vivendo com HIV necessita de cuidados de saúde. Por isso nós fazemos juntamos todos os esforços para fazermos que eles tenham essa parte dos cuidados de saúde.
Que é uma oportunidade para trocarmos experiências, portanto, entre diferentes países. Estamos a implementar o mesmo projeto, sim, mas em contextos diferentes e as experiências de um país podem, portanto, ser adequadas para um outro país e dessa forma conseguirmos ter melhores resultados.
An AIDS-free generation is possible. We sure can achieve an AIDS-free generation. All we need is to purpose, to focus, and go where it matters.
Very intentional, really learning from what has been happening over 2020 when Breakthrough Partnership was launched. So we really want to understand what are the key lessons learned, what more can we do, and we're excited in this moment. So without further ado, let me welcome my wonderful, passionate young woman, Kathy. Welcome to the podium. I was feeling lonely, Kathy.
Will get you everywhere, Maxie.
Thank you so much. Over to you, Kathy.
Good. Thanks, Maxie. And good morning, everybody.
Morning.
Thank you for coming and getting up nice and early. So I'm just going to talk a little bit about how we set up the partnership, and then we'll keep going. Is it not good enough? Okay. Is that better? Okay. So VIV Positive Action set up this partnership back in 2020, and we brought together 4 incredible partners to work together, EGPAF, UNICEF, AIDS Funds, and PATA. And we had a really interesting workshop to decide where we wanted the partnership to operate, which countries we wanted to prioritize, and how we were going to work as a group of organizations, very talented, bringing lots of expertise and lots of skills to bear, different skills and complementary skills. So how would they all work together to make a difference to ending pediatric AIDS, which is our ultimate goal? So that was all back in 2020. And we agreed how we would try and address the gaps in the provision of the HIV response to children. And as we all know in this room, I don't need to talk about the gap. Everybody's fully aware that children were being left behind. And that was the purpose of bringing these fantastic organizations together to see if we work collaboratively, could that make a difference? That was our challenge. And we used as a basis for planning the work that we were going to embark upon, we used the UNICEF service delivery framework. So we had all the elements of the ways in which we could provide services to women, mothers, children in that service delivery framework. And we were looking for how each of the partners could bring to bear their skills and expertise, where were the gaps in the services, and how might we together try and address those gaps. So the partners agreed 3 priority countries, Nigeria, Uganda, and Mozambique, all at different stages in the HIV response, and specifically in the response where it impacts children. So we wanted to understand how that might work. So today, what we're doing is sharing that understanding that we've gained in those 3 countries. And each, you will see a presentation for Nigeria, a presentation for Uganda, and a presentation for Mozambique. Try and draw out the learnings to find out how we did, really. And the key focus for the partnership was coalition building, making sure we understood how we were going to work together. The clinic community collaboration piece is critical, and you'll see that discussed in the presentations as we go. And then kind of underpinning all of that was a strong advocacy plan as well, to see if we could ensure that through those advocacy plans, we could get other stakeholders, ministries of health, etc., on board with, if this collaborative approach makes a difference to the service for children, then how do we make that sustainable in the long term? So at VIV Positive Action, we invested about £9 million in the first phase, which we're going to talk the first 3 years of this incredible partnership. So I think what is clear for us at Positive Action is that the response for the HIV response for children, ending pediatric AIDS, remains a key strategic priority. And so this particular partnership was really, really important to us and remains important to us. So, and I think without further ado, we need to know what happened.
Yes. I totally agree, Kathy. Saying thank you so much for really providing the background. I can be really close to this and I relate with it because I myself am a young mother. I'm living with HIV and I have a beautiful baby boy who's negative. So I could really relate close because I know it's important work. Children and pediatrics have been left behind when it comes to HIV testing, diagnostics, as well as care support. So for me, this is an exciting opportunity, a really wonderful dialogue that we're about to have. And also the partnership from VIV, I really appreciate it because one thing that is unique is you promote collaboration, coalition building, partnerships, which is really unique because most of the times we love to do our programming in silos. It hasn't worked. So really collaboration, partnership is the way to go. Thank you so much, Kathy. I have to kick you off my stage. Thank you so much. Thank you so much. Let's clap hands for Kathy. Awesome. Okay, the exciting part. But before the exciting part, I think we have seen the wonderful, video that has been playing ever since you were coming in. This is one of the really, case study, or I can say really great work that has been happening in Mozambique, where they really document how they're working as partnership. But the important component as well is that they've been working with key stakeholders, with the Ministry of Health, with governments, which is important because we are working together and supplementing and complementing each other and building strong partnership with government as well. So that's one thing that we've seen through the video, as well as having the young mothers leading and also implementing themselves, which is something that we always drive. If you want to make change, make us, as the young mothers that are affected, be in the forefront. That's what the video was all about. Secondly, we've got translation. So if you want translation, go to the back, get your wonderful, earphones, and you'll be together in this conversation. Okay, now to my beautiful panelists. You're going to see them. They're very beautiful. Oh my goodness. So to my beautiful panelists, may you kindly join me on stage. Clap hands for them. Yes, find where you can sit. Please do come, keep clapping for them so that they can, yes. You see, I told you, and we are all women. Can you imagine? Someone is saying maxi but. Anyway, thank you so much for joining me on stage today, and thank you so much for really being here and sharing your key lessons learned. I will give you the voice so that you can introduce yourself in 1 minute. Who are you? Where are you coming from? What are you passionate about? I'll start to my right, going to my left.
Good morning, everyone. My name is Fatima Churis, and I'm with the Elizabeth Glazier Pediatric AIDS Foundation. And what I'm passionate about is being part of the history of ending pediatric AIDS.
Woohoo! Welcome, Fatima.
Good morning, everyone.
Morning.
So my name is Elga Gwamb. I am from Mozambique, and I work for UNICEF. So working for UNICEF, we're all passionate about working with children and their
Yes.
mothers, including adolescents. Thank you.
Welcome. Woohoo, indeed.
Good morning, everyone. I'm called Dr. Margaret Lang. I work with Pediatric Adolescent Treatment Africa, and I'm passionate about working with health providers, ensuring that they have the right skills to ensure comprehensive service delivery for children and adolescents.
Welcome, Dr. Margaret. Can you see her? Okay.
Good morning, everyone.
Morning.
My name is Aisha Dadi. I work with the Society for Family Health Nigeria. We implement for the AIDS funds and the partnership.
Aisha, what are you passionate about?
I'm passionate about children generally. I want to see healthy child, including not having any child born with HIV.
Yes, I am right there with you. Welcome, everyone. So we're gonna quickly jump into our presentations. I'm not gonna name them, and I'm not gonna call you. We know how we plan together. So tonight or today, oh my goodness, I'm so sleepy. My apologies. So I think this time I'm gonna go to Nigeria. So I'm gonna give this opportunity.
Hello, good morning once again. It's so exciting to be part of the team and working towards ending pediatric AIDS by 2030. And it's workable with all of us here. So I'm going to be taking us through coalition building that we're doing in Nigeria. And okay, can we? Please, next slide. This is not moving. Please, technical team, can we move? Okay. Yeah, we're working in Nigeria as part of the Pediatric Breakthrough Partnership to end pediatric AIDS by 2030. And the partnership, as we already know, we have the child at the center of the conversation. And we have AIDS funds that is focused on comprehensive community engagement. UNICEF is engaged at the global advocacy, and we have PATA that is building the capacity of healthcare worker and monitoring quality improvement plan for the services provided at the facility level. And ECPAF is ensuring treatment optimization and also treatment failure around children. Next slide. Sorry, sometimes technology is not a friend. Please move backward. Okay. Now, in this partnership, we are working in line with Global Alliance to ensure that children with HIV receive care. We also want to prevent vertical transmission for pregnant women and during lactation. And above all, UNICEF is ensuring that this happens at the global level through strong advocacy. Next. Next slide, please. Okay. Now, what are the focus of this partnership? The focus of this partnership is that we have 4 partners who have come together to end pediatric AIDS by 2030. And we have one proposal. The 4 partners have one proposal to give positive action. We have common work plan. We have one M&E dashboard, regular review meetings, joint supervision, supportive supervision, and at the end of every year we have joint reports that is submitted. Next slide. Okay, what are the lessons learned so far? we've been able to streamline efforts and resources in the course of the partnership, and impactful partnership and alignment of activities, and we have better outcome and accountability of all the activities that we carried on so far. And in Nigeria, we are implementing in Rivers State and Taraba State, where we have Taraba State, we have 10 local governments and 20 facilities that we're working in. And we also have in Rivers State, we're working in nine local governments and 9 facilities. At the national level, we've been able to support the national response, which include supporting the national acceleration plan for pediatric and adolescents. We are also currently having a collaboration with Zoe Life in South Africa. We all know how we all clamor for age-appropriate disclosure. So in order not to invent the new wheel, so through SFH and funding from AIDS Fund and VIV Breakthrough, we are working to ensure that the documentation of age-appropriate disclosure in Nigeria come to stay. And one extra and some remarkable partnership that we have done in Nigeria also include that we have pediatric and adolescent focal person in all the 36 states plus the Federal Capital Territory. This was not there in Nigeria before the advent of this breakthrough partnership. We're also supporting we also supported the pediatric adolescent package of care in Nigeria, and we're working. We also worked to ensure that quarterly we have pediatric and adolescent tax team in Nigeria. So without some of these activities that will bring all the necessary stakeholders together to make sure that we have a robust system, robust program that is focused on data sharing. Without us knowing what the data is saying, we may not be able to know what is actually happening with pediatric and adolescents. This was brought together by the partnership in Nigeria. Next slide. So I want to tell you thank you so much, and also tell you that this is Tenanta Nekotura. So thank you very much for your attention.
Thank you so much. Thank you, Dr. Aisha. Thank you so much. As you take your seat, thank you. Let's clap hands for Dr. Aisha. Okay, over to you, Dr. Haig.
So, good morning, everyone, again. And in Portuguese, we say bom dia. So please repeat with me, bom dia. Bom dia. So some of you have heard bom dia, so yes. I'm going to be sharing our experience in Mozambique in Breakthrough Partnership regarding the community linkage with health facility. So I want to thank you for coming here and the opportunity for us to share the experience during these years of implementation. And I'm going to be presenting these on behalf of all Mozambique partners. So going into the next slide, so I'll ask the technicians there to help me. So we have 4 partners, you have already heard, and each partner, they have their own responsibility. So some partners are more focused on community interventions, and the other partners are more focused on health facility interventions. So we have PATA, who is responsible for doing capacity building, both for health workers and also community actors. And then we have AIDS Funds, who is represented by Nweti in our country, and they are responsible for community interventions and make sure that the patients that they identify at the community level, they are referred to the health facility. And then we have UNICEF, that it focuses most on advocacy at all levels, but then during the first phase, we were also implementing some interventions related to innovative technologies for multiplexing of early infant diagnosis and viral load at the health facility. So with the demand creation that Mweti was doing in the community, people were referred to the health facility to do the early infant diagnosis and also to seek for care and treatment. And last but not least, we have ECPAV, who is responsible for care and treatment of pediatric and adolescent patients. So next slide, please. How did we work? So the partnership holds meetings, coordination meetings with key government people. So we were doing coordination meetings at all levels, so national level, provincial level, and including health facility level. And these coordination meetings, they were aimed to strengthen the linkage between community and health facility. We also involved community actors, because we cannot work in the community if we don't have the community actors active, if they are not engaged, if they don't participate in the development of the model as well in the implementation of it. So we involved them, and together with the community actors, we managed to improve referrals to the health facility, and thus contributing what is we call 95-95 targets, which are UNAIDS targets. Also, the community actors, they supported us in demand creation for the health facility. So in this way, many people were able to have access to health services. We also implemented what we call community-led monitoring, where community actors and health workers, they sit together, they talk about the barriers that influence quality of services, and they design a plan, action plan, so that they can implement it. And the community also monitors it at the health facility to see if what they have discussed and the plan that they have made, if it has changed or not, and if it has improved the health services, the quality of the services. So in this slide, I'm showing you many of the activities that we do, both at the health facility and community level. These activities, they are connected to each other. So as I mentioned in the beginning, we do build capacity building to the health workers and to the community actors. And with this capacity building, the community actors are able to do testing at the community and refer these people to the patients to the health facility, so that they are linked to the health care services and they can receive treatment. And also, with the demand creation from the community health workers, we are able to implement early infant diagnosis of children that were found at the community, and also provide viral load to the mothers, including adolescent. We also have interventions, we call it peer support models, such as mentor mothers, young mothers, that they implement both at facility level. There it's where we enroll patients, and then we refer them to the community as well. So they also work in the community, providing them with counseling at the community level through home visits and other groups. And we also have what we call community-led monitoring that I explained already before. I'm not going to repeat that again. And we also implement activities that provide economic strengthening, such as village saving and loan groups, and also income generating groups, to make sure that they can continue adherent and retained in services, as well as not worrying about their economic status. So last, I'm going to share some of the results that we had during this time of implementation. And they are not all, but I think we can share what I'm bringing here. So as I mentioned, we increased the demand creation for early infant diagnosis and viral loads to 64%. We also managed to link the people that were tested positive in the community 98% of them arrived to the health facility and they had access to care and treatment. And we also trained about 116 community actors, and we provided them the skills that they need to offer quality services. And also we managed to maintain people in the program retained to the care and treatment. So with this, I would like to say thank you.
Thank you so much, Dr. Hag, and for really showcasing why it is important for us to have community facility linkages. Thank you so much. I'll move on to Dr. Margaret. Over to you. Let's clap hands for Dr. Margaret.
Good morning once again. Yeah. So also just to note that the activities that that the previous presenters have talked about are also being implemented in Uganda. But for the purpose of this presentation, I will concentrate on advocacy that we are doing. Okay. So overall, Uganda is on the right trajectory to achieve the UNAIDS 95, 95, 95. But like you all know, children continue to lag behind. And so when they compare the children's statistics, for example, in retention against the adolescent, well, the national statistics against children and adolescents, you find that actually there is a glaring gap. Now, in April of last year, there was a meeting that was organized by the Ministry of Health, convened by UNICEF, and a lot of partners were invited, all the implementing partners in HIV. And so there was a review of the HIV response in relation to children and adolescents. And indeed, it was noted that there were gaps in policy and there were also gaps in resource allocation. So at the end of the day, partners had to come together, again convened by Ministry of Health, EGPAF, PATA, UNICEF, and AIDS funds. So in the subsequent meetings that were held, every partner was able to bring their competitive advantage. And in this case, UNICEF was able to convene all the AIDS development partners in the country. They were able to reach out to the different ministries. So that's the Ministry of Gender, Ministry of Education, Ministry of Health. And they were also able to bring on board the civil society organizations and also other partners that are relevant to that field. AIDS Fund, on the other side, or on the other hand, was able to bring the community voice in this discussion. And then PATA was able to bring health providers from different health facilities to this conversation. And then EGPAF was able to also bring on board the discussions around health system strengthening and the activities that are needed to make this successful. So at the end of the day, we're able to come to develop the National Pediatric Strategy and Advocacy Roadmap for Uganda. Now, in this roadmap, when you have a look at it, you will notice that we're able to highlight 6 areas, 6 advocacy areas of concern. And in these advocacy areas, you'll notice that we looked at the insufficient pediatric and adolescent data that is currently existing. We're also able to highlight the limited PMTCT and EID service delivery at the lower health facilities. Also, we looked at the limited access to viral load testing, limited community health engagement for children and adolescents living with HIV, and also it was brought on board that schools are not adequately prepared to handle children who are living with HIV. So in the advocacy actions that are captured that we hope to monitor and see how it's implemented is that, for example, we want cabinet approval for the rollout of the school health policy that has been on the shelf for the last 19 years. So we hope to see that happen in 2024. A 5% annual budgetary increment to the school health board, revised teacher training curriculum on how they can handle children who are living with HIV. And yeah, so there are 8 action 8 actions in that advocacy. Yeah. So the other advocacy activities that were done as a partnership include things like in the summits. As you're aware, PATA always has summits every year. And so we were able to get the different contributions from the partners in this summit to make it more engaging and successful. And then also at the country level, the partners were able to support one of the organizations that's work with adolescents and young people, that's UNIPA, to have their annual Y+ Summit. And in these summits, they're able to hold stakeholders accountable to, for example, sexual reproductive health rights and other activities around HIV. As a partnership, we've also been able to advocate for the review and the development of the training curriculum on treatment literacy. And these have further been developed also into job aids, and they've been disseminated up to the ground. Then we've also been involved in the review and revision of the HIV prevention and treatment guidelines that came out in 2022. And also we've been able, as a partnership again, to come up with advocacy toolkit for training young peer supporters to be able to support their fellow adolescents and also voice their concerns, and the same for the health providers. Yeah, and then we've also been involved in the health system strengthening, which has been spearheaded by ECPAF, being able to convene all of us. And through this, there've been some reviews in the district budgets. And so we've seen some renovations being done at the health facilities, a construction of health provider accommodation, so that they're able to stay around the facility and provide services. So in a way, staff absenteeism has been handled. And then my last slide, please. Okay, so also we have been able to engage the community and document the impact that the project has been having in the community, because the project has been implemented for 3 years now. And so the community voices that have been documented, they've shared their journeys and how they benefited on the project. Thank you very much.
Thank you so much, Dr. Meg. I'll tell you a joke about the technical people at the back later on. Thank you so much. I'll hand it over to Dr. Fatima. I think Dr. Meg, just in her closing, highlighted the importance of documentation and what can we do, without evidence. So I think my question to you is, what are the contextual implementation lessons and evidence that we have really seen over the years, especially to inform broader planning as we look into the future as well? Over to you.
Thank you for that question. So I think as a partnership, we've recognized that better evidence equals better health outcomes for our target population. And as such, and as presented in one of the slides, as a partnership, we came together to identify what were the key indicators, not only outcome indicators, but also process indicators that really reflect the universe of the work that is being supported by this partnership. As highlighted in the various presentations, the partners are working at the community level, at the capacity building level, at an advocacy level. So how do we capture all of those elements in a unified way so that we could really understand what impact we're having? And as such, we've come up with a unified dashboard that we are using to look at our progress. What's been very interesting also is to see how some of the individual activities, whether they be at facility level or at the community level, because we have this partnership and we are coming together in annual meetings, there is some south-to-south learning that's happening as well across countries. So what's working in Uganda can be applied in Mozambique. What's working in Mozambique can be applied in Nigeria. And tailored to the local context. I was recently in Uganda, and one of the personal stories or one of the initiatives that was supported under the partnership was a secondary health worker model. And this model was implemented to support achievement of viral suppression in young children who historically had had challenges in achieving viral suppression. What we're trying to do is actually identify how long the support takes to achieve viral suppression in an individual case compared to the standard of care. We've had such great success that intervention is now actually recommended at national level as a model for supporting children to be retained in care and achieve viral suppression. So to advocate for changes in policies, but changes in guidelines as well. And we're also supporting the costing. We know these funds are catalytic, and we want to ensure that they are sustainable. So the importance of documenting the cost elements of these individual interventions to help inform sustainability in the long term. Thank you.
Awesome. Thank you so much, Dr. Fatima. Let's clap hands for Dr. Fatima. And I think really thank you for sharing that. And one aspect that we definitely forget in our implementation is the costing part, which I really appreciate in this wonderful project. Okay. I think we have heard it all. We have come from coalition building, community facility linkages, and we went to advocacy and evidence. What more can you want? I think it's a great package, right? So let's clap hands for them. Once more again. Awesome, awesome. So here's an opportunity for you guys. I only want only two people, the first ones, to ask us question, not me, but these wonderful 4 panelists plus Kathy probably. Oh, so we have only one? Okay. How can I prioritize? Yes, 1, then we have another one here, 2. So let's see how we do on time. Then I can pick up other people as well. That mic, I can multitask.
Thank you.
I told you something about IT people, right? Hi. Yes. Yes.
Yes, they are coming together in partnership, but I seem to miss something. You are there, you are 4. Where is the 5th eye who is actually playing the oversight role to say we are coming together, we are going in this direction in terms of sort of designation indicator, provincial or district indicator? I'm not seeing that. That is missing. We are providing services to the children.
Yes.
Who is going to say this area is working? This is not actually moving. We have got the same sort of approach in terms of the James local.
Okay.
Where they are in service.
Yes.
But we've got a focal point where who can actually sort of play as a referee to say we are missing this. This child didn't get a full package of the service. Yes, we are implementing as 4 or 5, but now we are missing this. So I'm checking who is playing the oversight role in all those coalitions because they have to from where?
Yes. Yes. Thank you so much, sir. The presenter has noted. Second question, please. Yes, sir. Morning. Yes. Welcome. Mhm.
In the presentations, there was a slight mention of the community.
Yes.
I want to find out.
Yes.
Within the principle of co-creation, what was the role of community leadership? I'm talking about traditional leaders,
Yes.
religious leaders,
Yes.
youth leaders,
Yes.
and other leaders.
Very important.
I ask this question because meaningful community involvement
Yes.
is a critical success factor to sustainability.
Definitely. Thank you so much, sir. Let's clap hands for my two questionnaires. I don't know if that's the word. But anyway, I will give it over to my panelists. Over to you.
So thank you for the questions. I hope you can hear me. Regarding the first question, as I said in my presentation, we are implementing under leadership of the government. So before we started this partnership, we went to the government, and together with them, all the partners, we looked at the government data, national data, and then from there we identified the gaps and we identified the places where we can implement the activities. So we decided that we were going to implement in one province, which is called Inyambani, and from there we selected the health facilities that they were most behind regarding the 95-95 targets, and also regarding PMTCT in general, quality of services, high positivity rate of children tested, and also retention rate. So we looked into many indicators, and from there we decided together with the government where we are going to implement. So the government is our biggest ally here, and we are implementing together with them.
Yes.
So we didn't have time to explain a lot,
Yes.
but we go, for example, to supervisions with the government, to the health facilities and community for them to see what is going on there, what is working, what are the challenges, what are the good practices, and then together we can use evidence to showcase and also change policy, change guidelines, and improve the quality of services in Mozambique. So going to the next question, that was regarding the community leaders. Yes. So also I mentioned in my presentation that we have community dialogues as one of our interventions. Community dialogues, they are held in the community, and we have the community leaders there managing this kind of meetings. And also when I spoke about community-led monitoring, we also have the involvement of community leaders, religious and other community actors that are in the community. So both community and health providers, they have meetings in the community, and they discuss about what are the barriers that are influencing quality of services at health facility, and then they design a plan to overcome these barriers and improve the quality of services, both at health facility and also community there. As I also mentioned, we have, for example, peer support models. We have mentor mothers that they work both at health facility and they also work in the community. And these mentor mothers, they can bring their experience and also support the health facility to improve the qualities that are given there. So thank you.
Dr. Mike, thank you so much. Dr. Hag, thank you. Yes, Fatima, 1 minute.
Yes, so I just want to compliment the answer around community engagement, because I do think it's so critical. The community is so engaged in the work that is being done that I recently attended a support group where the village mayor was actually part of our viral suppression group. They took accountability of overseeing some of the orphans and vulnerable children in their community setting in order to ensure that there was support provided to ensure the child achieves viral suppression and enrolls in school. So I think the community is front and center and so critical to the success of the program. So I just wanted to compliment that because I think that is it goes beyond just traditional leaders.
Thank you so much, Fatima.
Thank you. I also, okay.
Just 1 minute.
Okay, 1 minute. I also want to add to what my colleague just said, that government is playing the overall coordination in all the activities like that we do. Like in Nigeria, when we